Today, we're diving into a medical mystery, one that can be absolutely terrifying for new parents. And it all starts with a single but incredibly alarming symptom. So picture this. You have a newborn just a few weeks old. They finish feeding, and then all of a sudden, they vomit. But we're not talking about a little spit up. This is forceful, projectile vomiting. I mean, milk flying a foot or two across the room. It's really alarming, and it's our central clue to solving this whole thing. So let's start our investigation right there with that one dramatic symptom. Not all vomiting in infants is created equal. What we're talking about is completely different from the mild spit up you see with reflux. And here's the most important part. The vomit is non-bilious. That means it's just milk, no yellow or green bile. That single detail is a massive clue for doctors. It tells them the blockage is happening before the food even gets to the intestine, which helps rule out a lot of other serious issues. Okay, so if the problem is happening before the intestine, we've got to look at the anatomy of the stomach itself to find our culprit. The key player here is a little muscle called the pylorus. The easiest way to think about it is like a muscular gate. It's the doorway that controls when food leaves the stomach and enters the small intestine. And normally, this gate just opens and closes, no problem at all. But here's where the problem starts. For reasons we don't fully understand, that pyloric muscle starts to thicken and get bigger. As it gets bigger, it squeezes that gateway shut, narrowing the opening. So now the milk can't get through. It just builds up and backs up in the stomach. The stomach, trying to do its job, contracts with incredible force to push the milk out. But with the forward path blocked, there's only one way for it to go: back up. And that's what causes that powerful projectile vomiting. And this whole chain reaction has a name: Hypertrophic Pyloric Stenosis, or HPS for short. The name actually describes the problem perfectly. Hypertrophic means overgrown muscle, and stenosis means narrowing. So there you have it, an overgrown muscle causing a narrow outlet. What's really fascinating is how specific this condition can be. It almost always shows up when a baby is between 2 and 8 weeks old. It's way more common in firstborn babies, and, get this, it affects boys about 4 times more often than girls. There are also some noted links to formula feeding and even the use of certain antibiotics right after birth. So, we know what HPS is. Now let's put on our detective hats and see how doctors piece together the clues to solve this mystery. All right, clue number 1 is the big one we started with. It's the absolute hallmark sign, the calling card of HPS, that forceful, non-bilious projectile vomiting that happens right after a feeding. This is almost always the symptom that gets parents to pick up the phone and call the doctor. Now, here's a really interesting and kind of counterintuitive clue. Even after all that vomiting, the baby is starving. They want to eat again right away. This is what's known as the hungry vomiter, and it's a classic sign. It shows that the problem isn't a lack of appetite. The baby wants the food. Their body just physically can't get it where it needs to go. The third clue is one a doctor has to find. In about half of the cases, that thickened pyloric muscle is actually big enough to be felt through the baby's belly. It's famously described as feeling like a small, hard olive. It's a direct physical piece of evidence of the problem. So, when you put all these clues together, you get what doctors call the classic triad of HPS. You've got the projectile vomiting, that palpable olive mass, and sometimes you can even see the stomach's forceful contractions as visible waves moving across the baby's abdomen. When a doctor sees this combination, HPS jumps right to the top of their list. But to be absolutely certain, to confirm the suspicion, doctors turn to the gold standard: a simple, totally non-invasive abdominal ultrasound to get a crystal clear look. And the ultrasound isn't just looking for a general problem. It gives them precise measurements. If the pyloric muscle is thicker than 4 millimeters and the channel itself is longer than 14 millimeters, that's it. It confirms the diagnosis of HPS. It's a diagnosis based on cold, hard data. Lab work can reveal another piece of the puzzle. Because the baby is vomiting up so much stomach acid, they lose essential electrolytes like chloride and potassium. This creates a very specific chemical imbalance in the body. Medically, it's called a hypochloremic, hypokalemic metabolic alkalosis. In simple terms, the baby's whole system is thrown out of whack, and that's a telltale sign of just how severe things have gotten. So, we've identified the problem, we've confirmed it. Now, how do we fix it? The good news is there is an incredibly elegant and effective solution. But wait, before we even think about surgery, here is the most critical point. The number one priority is not rushing to the operating room. It's stabilizing the baby. All of that vomiting leads to serious dehydration and electrolyte problems, and that has to be corrected first to make any procedure safe. This preoperative care is absolutely essential. The baby will be given IV fluids to rehydrate, their electrolyte levels will be carefully balanced, and their stomach will be given a rest, and sometimes decompressed with a tiny tube to get them in the best possible shape for the procedure. Once the baby is stable, the definitive fix is a surgical procedure called a Ramstedt's pyloromyotomy. Now, it sounds really complex, but the idea behind it is actually quite simple and brilliant. The surgeon just makes a small cut in that overgrown outer layer of the pylorus muscle. This allows the inner lining to bulge out, which instantly opens up the passageway. The blockage is gone. And with that mechanical problem solved, the baby is immediately on the path to a full and really rapid recovery. Just a few hours after the procedure, the recovery begins. Feeding starts again, but it's done slowly and carefully. They'll start with small amounts, see how the baby tolerates it, and then gradually increase the volume. The path is now clear for milk to finally get where it needs to go. And honestly, here is the best part of this entire story. The outcome is fantastic. The surgery is a permanent cure. The problem does not come back, and these babies go on to grow, develop, and live perfectly healthy, normal lives. So think about it. We started with this really dramatic, scary symptom, and we ended with a straightforward, curative solution. Hypertrophic pyloric stenosis is just a perfect example of a medical mystery where recognizing those classic clues early leads directly to a happy ending. The real key isn't just the surgery, it's that swift, accurate diagnosis.